the impact of burnout on healthcare workers on equitable global health and ask what can be done, by whom, and to whom. My first year of practice as a doctor remains to date the worst year of my life. I'm not afraid to admit it. I cried each and every day, and I'm not a crier. Usually by 10:30 a.m. when the morning ward round was over. And this happened for 365 days. I can tell multiple stories, and stories makes it sound much less serious than it actually was, about why each day was such a cause of pain and stress and distress. I won't, because I'm certain that many of us here could tell similar stories about our experiences as healthcare deliverers. I do wonder sometimes why I'm still in the business and how am I still here? So many years later, why am I not burnt out? Or am I indeed burnt out? Suffice to say, burnout in healthcare workers is real and has real consequences at individual level and at systemic levels. The World Health Organization describes a functional health workforce as one that is responsive, fair, and efficient in achieving best health outcomes possible given the available resources and circumstances. This definition forms part of the WHO's 6 building blocks framework for health systems. The health workforce is considered essential for strengthening service delivery, improving health outcomes, and achieving universal health coverage. What is burnout? Burnout is a syndrome that consists of emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment. And this is driven primarily by workforce stresses. Depersonalization is characterized by impersonal and sometimes inconsiderate treatment of others. It serves as a self-protection mechanism. The decreased sense of personal accomplishment reduces the sense of competence and belief in one's own merit and ability to carry out their professional duties. Burnout is associated with psychiatric morbidity, absenteeism, and increased likelihood of attrition or retirement from the profession. Oops. So where is the crisis in burnout, the burnout crisis in healthcare? The Global Health Workforce Alliance, which was passed at the World Health Assembly in 2016, highlights a vision in which all people everywhere will have access to a skilled, motivated, and supported health worker within a robust health system. Depending on your source of data, around 42 to 63% of healthcare workers report burnout symptoms. The statistics from Africa as a continent put burnout prevalence in healthcare workers at somewhere between 40 and 80%. These data are compounded by growing workforce shortages, paradoxical unemployment and underemployment of healthcare workers, and reduced budget allocations to healthcare wage bills. In Kenya, where I practice, the ratio of healthcare workers per 10,000 people is 30.14. That's a significant improvement that's been achieved by increased healthcare worker training over the last 2 decades. However, it is only 2/3 of the Sustainable Development Goal threshold required to deliver universal health coverage and other ambitions. Nurses, physicians, younger healthcare workers, and women are more vulnerable to burnout. The factors associated with burnout are listed here: high workload, lack of social or organizational support, frequent night duty, poor remuneration, and workplace conflict. Interestingly, women in healthcare cite a lack of professional development opportunities as a reason for leaving the profession. Burnout is also linked to increased medical errors, poor quality of patient care, and lower patient satisfaction. Among healthcare workers, it is associated with diminished job satisfaction, strained personal relationships, substance misuse, depression, and suicide. Importantly, in healthcare organization, it contributes to reduced productivity, high staff turnover, and premature retirement. In fact, well-being of healthcare workers is increasingly being recognized as an important indicator of quality in healthcare delivery. Amid the mounting pressures on healthcare systems, Africa's youthful demographics, a shift towards non-communicable diseases, rising workloads, and uneven distribution of healthcare workers with rural shortages, services are increasingly strained. At the same time, policy ambitions such as universal health coverage speak to raised expectations for equitable, high-quality care in Africa. Although the number of healthcare workers has grown, this expansion has not kept pace with the population needs and disease complexity, and it leaves a persistent workforce gaps and has added pressure on frontline work staff. Healthcare worker burnout further intensifies these system pressures by driving attrition, outmigration, the so-called brain drain, absenteeism, reduced productivity amongst those on the front line. As workforce gaps widen, the remaining staff face even greater demands, creating a cycle that undermines both provider well-being and the quality of care that they deliver. Can we look at this from a systems perspective? Such a framing can forge a link between individual well-being of practicing healthcare workers and the systems within which they are working. If we take a holistic view of health to include health providers' own health as part of the ecosystem, it is a mindset that extends to recognizing that if they are not well, the care they deliver is compromised. It legitimizes conversations about healthcare providers' burnout, mental health, and lifestyle factors. Like ecosystems, influence disease, workplace environments shape healthcare providers' well-being, and this perspective can encourage system-level interventions. So what about the definitions of resilience? And there's a little bit of, let's say, controversy about this. So resilience, if you take it from the Dictionary of Psychology, is the process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands, with three key tenets, which are emotional regulation, coping strategies, and self-awareness and self-compassion. However, there is some debate around how resilience in healthcare workers should be understood and defined. Is resilience an innate personal trait, or a set of skills that can be learned and strengthened over time? Is it truly modifiable, especially in the face of chronic system pressures? Some critics argue that emphasizing resilience risks implying individual weakness or failure when actually support is needed, potentially shifting attention away from organizational responsibility. Others view resilience as a practical, teachable competence that allows us to adapt, recover, and continue to function effectively in demanding environments. There's a multitude of conceptual and theoretical models of resilience. This is one example, the 7 C's model of resilience, which describes resilience as an interplay of 7 elements that enable individuals to adapt positively and recover in the face of adversity. So, what are the interventions that can build resilience? I'm going to talk about them on a personal, organizational, and a system level. I've mentioned the predictors of burnout in healthcare workers. There are many interventions for personal factors that increase the risk of burnout. Some of them are listed here. Among the more well-known are organization-led initiatives like mindfulness workshops, self-awareness, and self-care initiatives. These include realistic goal setting, managing expectations, nurturing reflection, and gratitude to promote emotional regulation as a means of stress reduction. Mentoring and peer support can be a low-resource, sustainable way to support and build resilience. Establishing strong social networks is vital, as was seen in the early part of the COVID-19 pandemic. Now, here's a thought about recruitment. Do we recruit for the very traits and behaviors that predict burnout? The evidence seems to point that way. Hardworking recruits who say yes to everything, have a strong work ethic, never want to let their patients and supervisors down, who measure their self-worth by career success, may be the very material for burnout and other stress-related psychological morbidity. What about at organizational level? Another long list here. Christina Maslach, an expert in the study of physician burnout, describes burnout as not a problem of the people, but the social environment in which they work. Many organization-directed approaches to burnout focus on fixing the work, not the worker. These interventions reduce stresses through task restructuring, workload review, supportive supervision, greater job control, all very laudable. Practical examples include limiting excessive work hours, strengthening team communication, and training in emotional awareness to improve team relationships. Some organizations have also introduced programs that are grounded in cognitive behavioral strategies, time management, relaxation, mindfulness, and self-awareness to support healthcare providers' well-being. But when asked, healthcare workers consistently report that individual resilience efforts are ineffective when there's no meaningful or sustained institutional changes. I want to highlight 3 specific targeted interventions for better health equity. In Kenya, 58% of the health workforce are women, the majority of these being nurses, midwives, and community health workers. In sub-Saharan Africa, this proportion rises to 70%. Women, who are 2/3 of the community health workforce, deliver the majority of last-mile healthcare in Africa, yet they are underrepresented in leadership and specialist positions. As frontline providers, they serve as the first point of contact, particularly in rural and remote areas. Initiatives to promote gender equity through opportunities for female professional development and advancement, equal pay, and removing existing cultural and social barriers for women can be an effective as part of a gender mainstreaming approach. Building on this proposition, task sharing, in which selected responsibilities can be reassigned from specialized clinicians to nurses and community health workers, is widely regarded as a constructive and necessary approach to improving access to care in the face of workforce shortages. But approach with caution, because unless this is well implemented and properly supported, there are the obvious pitfalls of role ambiguity, insufficient training for expanded roles, and the downstream impact on the quality of patient care. Finally, the maldistribution of healthcare workers in urban areas continues to undermine health equity. Despite the increase in the stock of providers in sub-Saharan Africa, addressing this gap requires a coordinated, multi-pronged approach involving government, policy and financing, regulatory training institutions, health service organizations, and local communities through strategies such as rural training pipelines, targeted incentives, and career pathways, and investments in infrastructure and living conditions that make rural practice both feasible and professionally rewarding. Health systems cannot sustain the current rate of healthcare provider burnout and hope to deliver equitable, safe, high-quality care. Addressing burnout is going to require systemic, not individual solutions. The first step is acknowledging that there is a problem and committing to measuring and studying it seriously. Well-being must be institutionalized as a long-term organizational value, supported by dedicated resources and clear strategies. This may require rethinking how we recruit, how we train, and how our curricula prepare healthcare workers for real-world practice. Finally, sharing knowledge and developing best practice hubs can help encourage best practice across institutions and regions. When we look at the research, the evidence linking resilience interventions to meaningful outcomes is surprisingly weak. Definitions of resilience vary widely, as do the settings and types of interventions studied, making comparisons difficult. Outcomes are influenced by many mediating factors, and many programs are poorly timed, not tailored to individual needs, and evaluated over follow-up periods that are too short to show sustained impact. So is there a way forward? What deeper changes beyond short-term interventions might truly allow healthcare workers to sustain resilience across a lifetime of practice? If we keep asking healthcare providers to be more resilient without changing the system around them, are we solving the problem or simply shifting the blame? Given the limited impact of the current approaches, we need to develop concrete strategies that could have a genuine impact on the lives of healthcare workers and affect the delivery of equitable healthcare globally. Thank you. That's my list of references.